treating with steroids, his bilirubin came down to 14.1. So basically we had few challenges in this case. That is, he had repeated episodes of hemolysis. So what is the cause for hemolysis? We didn't know. We didn't find out. We couldn't find out. On the background of cholestatic picture of jaundice with a high bilirubin and raised alk-phos and GGT. So that was the challenges in this case, and on the background of DVT. So that's what basically we wanted to present to discuss about what else could have been done for this patient, because we were left with queries for the diagnosis part. Yes. That's what we were thinking, sir. But cross-sectional imaging and plain CT we had done, ma'am, just after the ultrasound, which showed the similar findings.
IgG4 levels, one thing.
After starting the steroids. Basically, when he presented, we had advised him for liver biopsy as well as a bone marrow examination, but he was not willing at that moment. Since his symptoms improved, he wanted to go up for the follow-up, and when he came back again, then ultrasound guided biopsy was done. Yes. Yes. Lipid profile was normal, ma'am. Yes.
So we had a similar patient, in our center,
Yes,
and patient was HbA1c negative. So we just did the anti-HBC total and anti-HBS, and we found that anti-HBC total alone was positive. And then when we looked into anti-HBE, that was positive. And then when we went into the HBV DNA, it was more than 8,000. So I think important is you have done only, I think, HbSAg. So it's worth doing the other two parameters so that we don't miss an HBV, which is occult.
Yes.
So it is more like an occult HBV that's presenting as cholestatic.
Yes.
And the hemolysis, I think, in this patient is more due to CAM, most probably.
Probably, ma'am, because he had, but took CAM only for a day, ma'am.
Yeah,
he couldn't tolerate.
And why was
Maybe
azathioprine started ahead of the biopsy?
Azathioprine started afterwards, ma'am. He was initially treated with steroids
No,
only.
on what basis? What was the
We were thinking
indication?
of some autoimmune
No, but
pathologies,
liver
ma'am.
biopsy was confirmatory of autoimmune?
No, ma'am.
Then, I mean, how we justified in starting an azathioprine with this patient?
Basically, we were thinking of some immune hemolysis, which is repeatedly having episodes.
I don't know really.
Does the vinyl chloride come into that?
No, sir. It contained.
One of the things I think it comes with weight loss. It can come with profound weight loss. It can come with cholestatic jaundice. I think we should go back and check what he's an industrial worker. No, vascular, but it can come like the cholestasis, and it's one of those occupational liver diseases. You think vinyl chloride is one thing. They can come with profound weight loss.
Yes.
Hemolytic component coming, but
Yes. Wilson's workup was negative, sir. So initially we thought of Wilson's only because he had episodes of hemolysis on the background of cholestasis.
His alk-phos was very elevated, and there's a ductal reaction.
Yes.
If it's going to be due to some toxic cholestatic hepatitis, maybe I don't know whether cholestyramine will help or it might help. His alk-phos was 907.
He's not so symptomatic. As far as the itching is concerned, he is not complaining of itching. So I think if at all anything should help, steroid should help. This is most likely industrial.
The other thing that happens in many of these toxic patients, with Plex, you find a sudden drop.
Yes.
And moment you finish the third cycle and wait for 2 weeks, it goes back again.
Yes.
So sometimes I've discussed with Dr. LVK, we feel there's some problem with the MRP2, no, the exit of the conjugated bilirubin. And we're not able to relieve that cholestatic aspect MRP2. I've discussed with Dr. Harshad also, because some of them are unknown drugs. So he says that sometimes he started with rifampicin or a small dose of steroid, because it is something that has affected the outflow of the bilirubin glucuronide.
Yes.
So moment the plex is given, it comes down and then it goes back. So the basic defect is in the MRP2 exit, canalicular pathway. And that doesn't settle down. And in fact, some of these patients will go in for liver cell failure and they have to, I think that patient came back to LVK for a liver transplant. Eventually we lost him because he went in for liver failure over a period of 9 months. It's typical that occult HBV. I think that should be done in this patient and then follow up the patient within 6 to 9 months, they go in for a liver cell failure.
That's what actually, ma'am, sadly, we followed him, ma'am, on telephone, ma'am. So, after getting discharged in 1 month around, he passed away because of some breathing
That's
difficulty.
what this
We
is
didn't know
classical.
the follow-up is.
And that same patient which I was mentioning as occult HBV I referred him to Dr. LVK for a liver transplant. And within 9 months, we lost him. The HBV came down, he became negative, but the liver cell failure took place because the bilirubinostasis, it's called, that does not get relieved. So maybe there's a role for rifampicin. I've discussed with Dr. Epen also. The other one is, of course, small dose of steroid, but it doesn't help. They are candidates for liver transplant. That's what I feel.
Yes.
So I have a basic doubt. So this patient had a profound cholestasis with alpha GD elevated. How common we see such scenario where the patient doesn't have itching at all? Does it give any because I remember profound cholestasis, but no itching can happen only in sepsis.
The BSEP pathway remains intact. The bile salt export protein pathway remains intact.
So that helps.
So the cholestasis does not take place. The patient will have intrahepatic cholestasis at the canalicular level, but the BSEP pathway remains same, the exit pathway. But the MRP2 gets tightly bound. What binds it may be one of the industrial product, but I'm not certain about that. But it is something that is stuck on to that MRP2. It just does not come out. We've seen quite a few cases like this. And they land up with a liver transplant towards the end.
Alpha fetoprotein we didn't do.
Because DVT also, we don't have a lead. I mean, I don't know, but whether paraneoplastic, I mean, it's only a thought.
So if it becomes one of those syndromes where you have a very small tumor, maybe
But
your
whether
alkaline phosphatase could be elevated because it's not really cholestasis, but it's secreted by the tumor.
yes.
So, Doctor, hello, sir. Sir, anything you want to comment on this case?
No further questions. Well done.
Thank you, sir.
It will be easier if you have known an answer.
Yes.
Well done.
Thank you, sir.
This is by Dr. Silambarasan from Stanley Medical College. The topic is a trident.
Good evening to one and all present here. I am Silambarasan, postgraduate from Professor M.S. Revathi Ma'am's unit, Department of NGE, Stanley Medical College. I am here to present an interesting case which we titled as a trident. Coming to the case, a 17-year-old female presented with yellowish discoloration of eyes and urine for 8 months duration, which was insidious in onset and gradually progressive, and the onset of jaundice was not associated with any prodromal symptoms. and followed by generalized itching and fatigue for 6 months, and there was a history of intermittent episodes of fever which was 1 to 2 episodes in a month